Okay, so today we're going to cover a topic. I'm going to cover medical gaslighting, which I think can come by a couple of different names, but it's popped up in the news in the last several years and in social media, so it seems like something that we ought to be at least giving a little bit of attention to. So, gaslighting is a term that originated from a British play from 1938. It was later adapted into a film, a British film in 1940, and then an American film, which became much more popular in 1944. It's a story of a married couple. Everything is super sunshiny in the morning, but over small incidents that you see throughout the film, there becomes more intensity, more anger, and a lot of confusion on the wife's part. But the gist of the whole thing is that the husband is trying to make the wife believe that she is insane, all the while keeping her increasingly socially isolated. So cutting her off from her friends, from her family. And it's called gaslight because one of the things that she started to notice that sometimes it seems like the lights in her room, because, being from the 1930s, sometimes the gaslight would dim as if there was a different light on somewhere else in the house, which she thought she was, that there couldn't be anybody else in the house, so that she was crazy. She would ask her servants and they'd say, no new lamp has been lit. So she thinks that she's losing her mind, which is the husband's intention. Gaslighting is a term of psychological manipulation. Usually that it happens to a person over a period of time. So where the victim begins to question the validity of their own thoughts, perceptions of reality, memories, leading to confusion, loss of confidence and self-esteem, loss of certainty around one's emotional or mental stability, and an overall dependency of the perpetrator of the gaslighting. The second definition of this, and this is directly from Merriam-Webster, an act or practice of grossly misleading someone, especially one to one's own advantage. So medical gaslighting kind of showed up in the online spaces several years ago. It's similar, but not limited to diagnostic overshadowing, something that we've talked about before. And medical gaslighting is when the culprit of the gaslighting is of the medical community. And I put unintentionally because I think that in the cases of the medical community, this is not intentional, but the medical personnel being involved in the process of undermining the patient's symptoms or credibility. Because of this, the patient might endure long periods of symptoms and discomfort, reducing their ability to function normally, reducing their overall quality of life, possibly impairing their ability to work or engage in education fully. Patients start to question whether or not they have a right to healthcare or even certain treatments. And we know that delayed diagnosis and treatment can have a devastating impact on health and overall mortality. The term medical gaslighting picked up traction over the last few years due to people finding a community on social media. While creating a space for people to share, find support, and highlight a problem, obviously social media has its downsides and that any kind of topic could spiral. So it's important to kind of keep in mind the space that this is in. And it was, I think, a Today Show piece on medical gaslighting that referred to it as the Me Too of healthcare, which is significant. It shows how impactful this is for a group of individuals. So medical gaslighting absolutely can happen, and it's going to happen more often to people who are already marginalized. So women, people of color, people with mental illness, that's where you see the diagnostic overshadowing piece. People with chronic or rare conditions, people who are overweight. There's lots of examples of marginalized populations having their concerns either minimized or misattributed to something else. So when it comes to diagnostic overshadowing, that misattribution tends to be, the symptoms of an undiagnosed physical illness being linked to an already diagnosed mental health comorbidity. But this can happen with symptoms of an undiagnosed illness being attributed to some other known illness. Or even to being overweight, things like that, lifestyle issues. Patients end up hearing things like it's all in their head, kind of leaning into that hysteria idea that had been common for a very long time. leaning into, well, saying, well, they're just uncooperative, they're not non-compliant, they just need to, and then, whatever the thing is, they need to rest more, eat better, exercise more. Usually some type of judgment about how this is, just if the patient would change something about their lifestyle and change some type of health behavior, then this would all be better. But it's really kind of that minimizing and not fully digging into or not fully exploring what the symptoms are, maybe not even fully believing what the symptoms are. There was an interesting article in this space showing that this could actually occur from professional to professional as well. The example being from a specialist medically gaslighting a general practitioner. So the Fraser article shares a story about a young female general practitioner trying to push a specialist to do more testing on her patient. The harder she pushed, the more she was dismissed, even being yelled at. And he started asking her questions like, how long have you even been practicing? Telling her that this was not her space, that he would take it, that he knew what was the appropriate test to run. And while later that day, or maybe the next day, she did end up getting an apology from the specialist, and she had already recognized this situation for what it was, and this specialist being overworked, tired, taking things out on her that had nothing to do with her. She did bring up a good point on how many young doctors might lose their confidence or their confidence be diminished because of being kind of spoken down to by somebody who's been in the field longer, who's maybe higher specialized. I mean, for any of our professions, whether it's physician, counselor, social worker, pharmacist, if somebody else is talking down to you, it could certainly diminish your ability, your feelings about your ability to do I even know what it is that I'm talking about? When very often people who don't necessarily have that hyper specialized training are the ones to catch things that could otherwise be missed because they have the good relationship with patients. There are way too many examples of this in the literature. So you'll see it in instances of cardiac disease, heart attacks, a lot of pain issues, a lot of women, particularly women of color, talking about not being believed about pain, issues of cancer not being diagnosed. I'll go over a couple. There was a New York Times piece that shared a couple different stories. One was a 32-year-old woman named Michelle, who wasn't diagnosed with lupus until after she was already experiencing kidney failure, a heart murmur, and pneumonia. The first doctor she had seen diagnosed her with allergies. The second thought that she was pregnant. They shared another story about a 42-year-old woman named Rami, who, when she was in her 20s, had been losing weight, losing hair, breaking out into a full body rash, had a doctor tell her that she was just young, healthy, and lazy before she was ultimately diagnosed with Graves' disease. There was a Today Show piece on medical gaslighting that shared the story about a woman named Maria who went to her doctor complaining of intense back and stomach pain. Maria shared that for 4 years, her providers told her there wasn't anything wrong, she simply needed to lose weight. Even when her symptoms got more severe and she started vomiting and losing her hair, her concerns continued to be dismissed. She noted in the story that she begged for a CAT scan, just please do something, please do testing, you don't know what it's like to live with this. And she finally started to believe them. She thought, maybe I am crazy. Then she ended up going to the ER, and she finally learned that she had a 25-pound cancerous tumor growing in her ovary. Thankfully, a team at Cedars-Sinai was able to remove the tumor, and she was living okay after that. Another story that I found actually led to a documentary that I've not watched yet, but I will certainly try to add it to my list, and it does appear that it's available for free. It's a documentary called Unrest by Jennifer Brea. It was a Sundance Award-winning documentary about her personal journey. She's 28 years old, working on her PhD at Harvard, and she was months away from being married when she had a mysterious fever that left her bedridden. Doctors told her it was all in her head, so she picked up her camera and started documenting all of this, only to later find out that she had a diagnosis of chronic fatigue syndrome, which, as all of you know, I think, that it's a devastating multi-disease issue that causes dysfunction of neurological, immune, endocrine, and energy metabolism systems. It often follows an infection and leaves 75% of those affected unable to work, many of which end up being homebound. So it has a tremendous, tremendous impact, but was undiagnosed for quite a long time. Interestingly, and kind of pointing to the data on this, women are diagnosed later. So when we think about this happening more often to women in marginalized populations, there was an interesting study in 2019 of a Danish population. So, you have to take that for what it's worth. It's not going to be a 100% direct, translation to US population, but I imagine we would see fairly similar data. But the researchers looked at 6.9 million people from 1994 to 2015 and realized that women were diagnosed with most diseases considerably later than men, with the exception of osteoporosis. So you could see that this later diagnosis was in connection with 770 different types of diseases. And there was an average about 4 years in between the diagnosis comparatively between men and women. When it came to cancer, women were diagnosed about 2.5 years later than men. And for metabolic diseases, it was about 4.5 years later. So why does this happen? So we know that science is more robust on certain populations. And just like the previous slide showed, we know that, certain populations, men have been studied longer, particularly white men have been studied longer than other populations. So we have more data. Clinicians often lack time, knowledge, and resources. That's just a reality of the system that we work within. Each one of those things needs to be addressed in order to touch on this, and each one of those could take up its own kind of large didactic. Bias, whether implicit or explicit, is going to impact people's judgment, and we know that when people are more stressed because of the lack of knowledge, time, or resources, they're more likely to fall into cognitive traps and things and lean more towards bias. And then discomfort with uncertainty. So there are over 10,000 rare diseases affecting over 30 million Americans. A rare disease being defined as any disease, disorder, illness, or condition that affects less than 200,000 Americans. And many of these are still being found. So many gaslighting anecdotes focus on the physicians attributing patients' symptoms solely to stress, poor nutrition, mental health, lack of exercise, or obesity. And people with autoimmune diseases have been subject to maybe some of the most severe medical gaslighting. Conditions like these can come with lots of non-specific symptoms like chronic fatigue and take a lot of really digging in to diagnose. And people are uncomfortable with uncertainty. There is one piece that I'm going to post into iEcho that I suggest that you check out. It's titled, "Why Won't They Believe Me?" And it is written by our former chair, Dr. Mark Munetz, and his wife, Lois Friedman. And it is a personal story about their daughter and the long, long search that they had to go through to help their daughter get help because of not being believed by the physicians that she was working with for many years. So some tips to spot medical gaslighting. It can be hard, but if you're in a physician's office, if you're thinking about this from the patient's perspective, red flags can include things like your healthcare provider not listening or interrupting you, diminishing your symptoms, blaming your symptoms on age, gender, weight, lifestyle, or sexual orientation, saying that your symptoms are probably due to stress or some type of mental health issue, and rushing you through an appointment. The example that they share on this slide was, a classic example of a 70-year-old woman who's worried about having more than usual body aches and low energy. And, the physician saying that's probably just aging without ordering tests. And maybe that's true, but also maybe it's not. And, sometimes we have to listen to people and see where they're feeling. So what can patients do? Be prepared. Know yourself, track your symptoms, be willing to ask questions, ask for clarification. So if you ask a doctor to run a test, and not all tests are going to be appropriate, and that's something very important for patients to realize. But one of the things that's suggested for chronically ill people is, when we're trying to teach them how to be their own advocate, is teaching them things that if I ask for a test and the doctor refuses to run that test, ask them to document that in the record and chart that not only did the patient ask for it, but why they decided not to run the test. What's the rationale behind not running the test? If nothing else, it protects, kind of the bigger picture of having your rationale documented, and that way if the patient goes to another provider, then they could see the kind of history of all of this, so people can get a better sense of what's really going on, and it's going to make the patient feel better. So as a patient, we can ask for that. Also, bringing support, bringing a person that can help you take notes, ask questions, listen a little bit differently. I know that for myself, I go to all of my husband's medical appointments with him because it's helpful to have a different set of ears. People hear different things differently. So just encouraging patients to do these things and to trust themselves. Being able to say, like, hey, this feels different. I feel different. This is not my normal. And just really pushing people to listen. And how might clinicians prevent it? A lot of this is around our communication skills and our ability to, self-manage what is going on in our own day, our own work life, maintaining a sense of narrative humility, making sure that we're engaging in person-centered communication and in shared decision making. Spend more time. That's an ideal. I know that's something that we all want to do and is not always possible, but maybe it's even just about reframing how you're spending your time, making sure that you're really attending to what it is that the patient is sharing. If you're noticing distress and how they're talking about something, taking a minute to really hear them a little bit more deeply. And obviously collaborative agenda setting. So I think we all have a space in this. Being mindful of our own biases too. And when we are starting to slip into biases, maybe because of cognitive strain, maybe because of fatigue, and trying to check ourselves. And as always, checking in with our colleagues to see if maybe we missed something. Here's a variety of resources that I pulled for pulling this together, and this top one, Munetz and Friedman, Why Won't They Believe Me, from Psychiatric Times. I will post in iEcho. I do highly recommend it. It is not the easiest story to read, but I think incredibly important for keeping us all mindful about the work that we do.